Hello, and welcome to the Clinical Liver Disease video series. CLD is the official digital learning publication of the ASLD. My name is Pranav Barman. I'm Assistant Professor of Medicine at University of California, San Diego, and guest editor of this edition of CLD titled Toolkit for the Transplant Hepatologist. I'm here today with Dr. Avash Kalra, Assistant Professor of Medicine and Director of Liver Transplant Outreach and Strategic Development at the University of Colorado. He's the author of Nutrition, Frailty Assessment, and Interventions for the Liver Transplant Candidate. Avash, thanks for joining us.
Of course. Thank you for having me.
We wanted to get your thoughts on this article, and we have a few questions to educate our audience a little bit further. First, this review focuses on the topic of frailty. What does that mean when we apply it to patients with liver disease, and why is it so prevalent?
Sure. It's a great question. And first of all, I was so excited to have the opportunity to write this review, given how prevalent of a topic this is in our practice. Frailty is a global, overarching medical construct, and when we apply it to candidates for liver transplantation, we're typically referring to physical frailty, so the manifestations and the consequences of the loss of their muscle function. I think many of us remember that classic textbook picture of a patient with advanced liver disease or decompensated cirrhosis. With ascites and caput medusa, for example. But part of that phenotype in that classic photo is a loss of muscle mass, thin arms and thin legs. And the consequence of that phenotype is frailty. So the goal of this review was to describe the many clinical factors that contribute to the development of that frail phenotype, and also to provide practical information that would allow a clinician to address modifiable factors. And so why to care? Why is this so prevalent? It is prevalent. It's present. Frailty as a construct of how we define it is present in over 30% of patients listed for liver transplantation, and that's likely an underestimate. And that construct of frailty has been strongly linked to increased waitlist mortality, decreased quality of life in patients awaiting liver transplantation, and certainly increased hospitalizations independent of liver disease severity. Frailty also worsens longitudinally without intervention and may even persist after liver transplantation. And so we felt this was an important topic to cover and address.
And why do you think we need to be focused on assessing it? Are there outcomes that we need to be paying attention to?
Sure. So as I mentioned, frailty is associated with poor patient-related outcomes, and those outcomes underscore the need for using specifically standardized tools to assess and intervene on frailty and also the associated condition of malnutrition in the setting of liver transplantation. We use, as we all know, the model for end-stage liver disease score currently as the foundation of the liver allocation policy in the United States. But the MELD score does not include an objective measure of a common clinical decompensation among patients requiring liver transplant, and that's poor nutritional and/or functional status. The MELD score is also a poor predictor for post-transplant mortality, particularly in patients who are physically frail. And so those factors underscore the need for exploring and using standardized tools to assess frailty.
Perfect. And speaking of tools, what tools would you say are available, and what tools would you recommend sort of a budding transplant hepatologist?
Yeah, so we like to follow guidelines, right? And the American Association for the Study of Liver Disease recommends, in their most recent guideline on this topic, recommends screening for frailty and malnutrition in patients with cirrhosis, including both compensated cirrhosis, whereby you might screen a patient annually, and decompensated cirrhosis, so screening every 3 to 4 months. Ultimately, clinicians can determine which assessments they want to use. I would suggest looking at tools that have been studied formally to be associated with outcomes in patients with cirrhosis in both the inpatient and outpatient settings. In terms of frailty, tools that have been studied include the Karnofsky Performance Scale, which is a quick, equipment-free, subjective measure of a patient's ability to perform activities of daily living and other tasks. The Liver Frailty Index is perhaps the most commonly used tool, and the tool that we use at our center here at the University of Colorado, an objective measure developed at UCSF, measuring physical frailty that uses grip strength, chair stands, and balance testing to categorize patients as either robust, pre-frail, or frail. And the Liver Frailty Index improves risk prediction of 3-month waitlist mortality for liver transplant compared to the MELD score alone. It also predicts post-transplant functional status. And longitudinal assessment of a patient's liver frailty index informs their mortality risk. And so that's a tool that I would strongly recommend for assessing frailty in patients. There are also several tools for assessing nutritional status. That's often done with assistance of a registered dietitian who specializes in transplant care. And we try to provide tables in our review that outline the different tools that are available for both frailty and malnutrition.
Thank you for doing that. And I might just end here with a question about your thoughts on strategies for intervention. I'm sure this is a sort of underdeveloped or understudied area, but since you are an expert in this area, what might you recommend as some strategies for intervention?
Sure. So I'd like to focus on a couple of interventions for the purpose of this talk. And one would be a nutritional intervention. So a lot of our patients who are frail, their frailty is directly related to malnutrition. We know from a robust set of data at this point that a key intervention for our patients with decompensated cirrhosis is promoting protein intake. So a protein intake of 1.2 to 1.5 grams per kilogram per day for adults with cirrhosis will help maintain a positive protein balance. It does not worsen hepatic encephalopathy to promote protein balance as such. And a related topic would be avoiding prolonged fasting to limit exacerbation of catabolism in these patients. So that is a significant intervention related to nutrition. We would also want to emphasize the importance of physical activity. So in patients who have muscle loss already related to their decompensated cirrhosis, their frailty worsens to the point where we often see these patients not able to walk without significant assistance. And so we promote daily physical activity, even if it's walking, to ensure that they don't have further muscle loss, which may impact their candidacy for transplant.
Thank you, Dr. Carl. That was extremely interesting, and I appreciate you sharing your thoughts with us today. Thank you again for joining us for another installment in the Clinical Liver Disease video series.
Thanks very much.